Hi, my name is Dr. Miriam Robbins, and I'm going to be talking to you today about oral care for older adults, a frequently overlooked issue. I have no relevant financial, personal, or professional relationships to disclose. And our overarching learning objectives today are to discuss the common signs of dental disease, what causes or contributes to dental disease in older adults, how to do an intraoral exam and an assessment, health conditions that can make oral hygiene a challenge rather than a routine, and then some preventive tips to improve patients' overall oral health. So the question is, have you seen this? And I would argue that if you say no, it means you have not been looking in your patient's mouth. Unfortunately, we know that oral disease is extremely prevalent. And as patients get older, the prevalence of oral disease increases. So in 2020, the Surgeon General issued a report called Oral Health in America, Advances and Challenges, which said that dental care was the most common unmet health need and non-communicable disease, or NCD, worldwide. And unfortunately, in 2024, that still remains a true statement. Oral disease can severely affect systemic health. We know that much oral disease, if not all oral disease, is preventable or at least controllable. There are profound disparities across ages and socioeconomic groups. Interdisciplinary care is essential. Healthcare is very siloed, and really, this needs to be sort of a multi-professional attack. And 90% of physicians think that oral health should be addressed at well visits, yet 50% had little or no oral health training. Only 9% could answer 4 simple oral health questions correctly. And in general, clinicians had less than 2 hours of oral health training during their professional training. So kudos to you for listening to this, and I'm hoping that at the end of this lecture, you will walk away with some clinical pearls that can help you in helping your patients. So this is a statue that is in the 8th Avenue subway station in New York, and I took a picture of it because I think it really sums up the problem. Somewhere along the line, the mouth got detached from the rest of the body. And we know that oral health is essential to general health and well-being. And if your mouth is not healthy, you are not healthy. And this, again, is from the U.S. Surgeon General report. So all dental disease, particularly caries and periodontal disease or gum disease, are plaque-related or bacterially based. Plaque is essentially a biofilm, and plaque is that, when you wake up in the morning and it feels like you have sweaters on your teeth, sort of the fuzzy feeling on your teeth. Basically what that is a biofilm that has been created by the bacteria in your mouth, and then, has an accumulation of food particles and, other things get sort of stuck into that biofilm. While plaque-related oral disease is generally not threatening, it has a negative effect on medical conditions and general health. So there have been a lot of work going into looking at the oral systemic connection. And if you subscribe to the philosophy that most diseases are inflammatory based, gingival inflammation, inflammation in the mouth is the most common source of inflammation in humans. There's been a lot of work in looking at the association with, for example, gum disease and preterm birth, periodontitis and cardiovascular disease. There's evidence to show that oral bacteria can play a substantial role in Alzheimer's. HPV-related oral cancers, periodontia, and rheumatoid arthritis. And so there's just this real continuing list of connections that appear to exist between inflammation in the mouth and systemic disease elsewhere. We know at the very least that plaque on natural teeth and dentures is a major cause of aspiration pneumonia, particularly in patients who are on ventilators. So ventilator-associated pneumonia is almost always caused by oral organisms. So it's a growing oral health need. Oral adults have increasingly complicated dental needs because, one, they're living longer, and they are living longer with their teeth. So dentistry has been very successful in helping people retain their teeth into their older ages. As people age, they have more chronic diseases and disabilities that put them at higher risk for developing poor oral health. So we know that 96% of adults 65 years or older have had at least one cavity. 1 in 5 have current untreated tooth decay, and 68% of adults 65 years or older have periodontal disease or some sort of gum disease. Now, there are no true aging changes seen in the oral cavity, but again, dentition is being maintained longer, and the longer you have your teeth, the more wear and tear on your teeth, the more chance there is for accumulation of oral disease over time. And again, there's an increase in systemic conditions that predispose patients to oral disease. So we do tend to see in the older cohort of patients a greater burden of oral disease. And there are some other contributing factors. Older patients have decreased immunity. Again, dental disease, particularly caries and periodontal, are caused by bacteria. And so when we see decreased immunity, we see more susceptibility to infections. You see decreased perfusion and decreased cellular turnover in all of the tissues, but particularly the tissues of the mouth. And then polypharmacy, with altered drug metabolism and increased side effects. We'll talk a little bit later in this lecture about the effect of xerostomia on the oral cavity and its contribution to oral disease. So there are many barriers to oral health for oral adults. First and foremost is finances. Medicare does not cover dental care, does not cover oral care. Recently, there has been some movement for some coverage for what is classified as medically necessary dental care. But really, routine dental care is not covered by Medicare. And so if you have a patient who has no other commercial or has not bought the dental rider, is relying on Medicare, they will have no access to dental providers. There may be physical barriers to access of care. They may have difficulty finding available practitioners in their community. They may have mobility issues and have difficulty finding a practitioner that has a accessible office. They may have difficulty getting transport to the dental office. There may be lack of social and family support. Very poor oral health literacy. So patients don't have the education or the awareness of what either needs to be done to prevent oral dental care, or they do not place value on the importance of having good oral health. So they have poor oral hygiene practices and poor preventive care practices. There are many systemic health issues that can have oral manifestations and systemic health issues that can cause patients difficulty in maintaining their oral hygiene. And then there are dietary and lifestyle factors that can play in. So many of you may routinely prescribe nutritional supplements for your patients, but I don't know how many of you know that 8 ounces of Ensure has 22 grams of sugar in it. And in fact, a couple of years ago, the New York Times actually published an article that said geriatricians beware of liquid candy. So something to consider when you're prescribing nutritional supplements. You may want to consider prescribing either the sugar-free variety or making sure that patients are aware that this is a very carcinogenic food source. So it's a food source that's going to promote the development of cavities. Now, all oral health professionals can be trained to distinguish between healthy and diseased tissues. Okay, my goal is not to turn you into an oral healthcare professional, but to have you realize that signs of inflammation and infection are the same no matter where in the body they occur. You don't need to be a dentist to look at the picture on the top and appreciate that, the tissue looks pink, it looks healthy. When you look at the picture on the bottom, you can clearly see that the tissue is erythematous. You can see some purulence. You don't need to be a dentist to appreciate that there's a difference between the patient in the top picture and the patient in the bottom picture. All right, so in doing an intraoral soft tissue exam is something that you should try to incorporate into your routine exam. If nothing else, this is my PSA announcement. 58,450 Americans were diagnosed in 2024 with oral cancer. There were 12,230 deaths. And the 5-year survival rate is approximately 66%. And that number has really not changed very much over the last 20 or 30 years. It's actually gotten a little bit better because we're seeing an uptick in HPV-related oropharyngeal cancers, which have a higher survival rate than oral squamous cell carcinoma. But the reason that the 5-year survival rate is so low is because often the disease is not diagnosed until it has already spread to regional lymph nodes or has distant metastases. And you can see that the survival rate goes down precipitously the farther or the more advanced the cancer is. So how do you do an intraoral exam? Well, first of all, you need a proper lighting. A dental mirror or disposable dental mirror is nice to have, but not essential. You can do this with a tongue blade. You need a 2x2 gauze, you need some gloves, and you need about 2 minutes. And, you can probably do it even shorter than 2 minutes once you get used to or comfortable with doing that. So I'm going to show you a quick video how to do this. It's important to remember, because the oral cavity is made up of mucosa and it's wet and it's curved, it's important that your exam be not only visual, but tactile, which is why the gloves are an important part of it. The first thing that you want to do is you want to take a good look at the lips, and you want to evert the upper and the lower lip and get a good look at the inside, the mucosa of the inside of the lower lip. All right, and again, you want to palpate to make sure that you're not feeling any masses. All right, and then do the same thing on the top and evert the upper lip and look under there. Again, make sure that you're not seeing any masses, ulcerations, or any obvious lesions. Take a quick look at the gums, see if they look swollen. Pull out and take a look at the buccal mucosa. And again, you're palpating just to see if you feel any masses and looking for any obvious swellings, looking for any obvious dental disease. If you take a 2x2 and wipe off Stenson's duct in a healthy patient or a patient with good saliva, you should be able to see clear saliva being expressed from the duct. So then you're going to have your patient stick out their tongue. You want to grab the tongue with the 2x2, pull it out and over to the side and get a good look at the lateral border of the tongue, which along with the floor of the mouth is the most common site for oral cancer. So again, you're looking for any obvious lesions, lumps, bumps, ulcerations. Have your patient put their tongue up to the roof of their mouth and look at the ventral surface of the tongue and take a quick look in the floor of the mouth. And again, at the same time that you're doing this, you can be taking a look at the teeth and the gums and seeing if you're seeing any erythema, any swelling, any obvious decay. Now you can do this with a tongue blade. I'm showing you here with a mirror. And basically what you're doing is, again, you're just pushing the tongue to the side so you can get a good look at the posterior floor of mouth. And then the last thing you want to do is to just do a quick bimanual palpation of the floor of the mouth. And again, what you're doing is feeling for any lumps, bumps, masses that might be present there. And then once you complete that, you can go ahead and do what you would usually do, which is to go ahead and have the patient say ah and take a quick look into the oral pharynx. All right, so Mrs. Brawny, I'm going to just show you a quick case. This is Mrs. Brawny. The patient is 79 years old. She's frail. She has mild cognitive impairment. She lives with her 83-year-old husband at home. She has diabetes, hypertension, cardiopulmonary disease, and osteoarthritis affecting both hands. And I would guess that most of you have at least one, if not many, Mrs. Brawneys in your practice. This is her medication. So she's taking metformin, aspirin, nifedipine, hydrochlorothiazide, ramipril, diazepam, Pazil, lorazepam, trazodone, Detrol, and acetaminophen. And what is significant about this list of medications is that she is on 4 medications that list xerostomia or hyposalivation or dry mouth as a major side effect. And so this is a good example of polypharmacy, where a patient is on multiple drugs that are all causing very similar side effects. Additionally, she's taking nifedipine, which is a calcium channel blocker, which can cause some gingival hyperplasia as one of its major side effects. So her chief complaint is my teeth are hurting, my mouth feels like I have cotton balls in it, and I'm having trouble chewing and eating. She's lost 24 pounds over the past 4 months. She used to go to the dentist on a routine basis, but has not gone in 2 years due to her worsening cardiac disease and decreased independence. When you take a look extraorally, you can see that she has fissuring and erythema present at the commissures of the lips, and this is the sign of candida. This is a candidal infection. This is called angular cheilitis, and it is caused by candida or fungus. When we look intraorally, you can see that she has this gingival hyperplasia. So you can see that her gums look very red and swollen, especially her in between the teeth. The gums are quite red and swollen. She has poor oral hygiene with debris present. Gingival tissues are inflamed and hyperplastic. Her saliva appears thick and ropey or sticky, tacky, and that's because, again, she's lost the serous portion of her saliva due to the medications that she's taking. What's left is the thick mucousy or mucoid portion of the saliva. And then she wears a partial denture, which she has out, and you can see that she has erythema present on the palate in a horseshoe shape, mimicking the outline of the partial denture. And this also is a sign of a fungal infection. This is erythematous candidiasis or denture stomatitis, so called because it is commonly seen under dentures in patients with poor oral hygiene. And, again, an important point is if your patient wears a denture, you should have them remove the denture, and you should take a look at the tissue that's underneath the denture base. Certainly you should be looking for any presence of any lesions under the denture. All right, so oral disease, again, is the most widespread chronic disease despite being highly preventable. And we know that the salivary microbiome is incredibly complicated. As, again, more is being discovered about the complexity of the GI microbiome. The oral cavity actually is part of the GI system and has, just a plethora of oral organisms, some benign and some pathogenic, but, just a real rich source of microbiome present in the mouth. So the microbiology of dental decay and periodontal disease. Again, I mentioned to you dental plaque. This is the yellowish microbial biofilm that builds up on the teeth. When you brush your teeth, you can remove this biofilm, and then as soon as you finish brushing, the bacteria in your mouth get to work building it back up again. There are two major categories of bacteria that we see in the mouth. We see aerobic and we see anaerobic. Aerobic bacteria or oxygen loving bacteria are the bacteria that cause cavities. So these are bacteria that basically take fermentable carbohydrates. They, as somebody I know likes to say, they eat sugar and poop out acid. And that acid then causes the destruction of the tooth structure. We see these bacteria again living on the coronal portion of the tooth, or the part of the tooth that you can see when you look in the mouth, and to the marginal gingiva. The second class of bacteria are primarily anaerobic bacteria. These live under the gums in an area called the periodontal pocket, and this is a space that exists between the gum and the alveolar crest of bone. These are alkaline loving, and these are the cause of periodontal disease, so gingivitis, which is the reversible inflammation of the soft tissue of the mouth, and then periodontitis, which is an inflammatory reaction that extends through the soft tissue into the epithelial attachment and to the bone or surrounding the teeth. All right, so periodontal disease. Again, what you're looking at here, you can see this sort of yellow, thick biofilm or plaque. You can see the related gingival inflammation, so this intense red erythematous band that's running along the gingiva on the top picture. And if you look at the bottom picture, what you actually are looking at is soft and hard tissue destruction with the presence of purulence and an actual infection around the lower front teeth as a result of the accumulation of tartar and calculus. So systemic factors that contribute to periodontal disease, smoking increases the risk substantially. We know that patients with poorly controlled diabetes have much higher rates of rapidly progressing periodontal disease. Stress, immune suppression, and then multiple medications in multiple classes can cause either overgrowth of the gingiva or because of suppression of the immune system, more predilection towards developing periodontal disease. And then again, we've mentioned already medication-induced xerostomia. And so periodontal disease is an inflammatory mediated response where, again, you start with this plaque, which then causes gingival inflammation or gingivitis. You get inflammation. That gingival inflammation then alters the microbiome, and it actually favors the prevalence of more pathogenic bacteria. So as you get the inflammation, things change in the oral cavity, and you start to see more pathogenic microbial entities emerge. You see this feedback loop where you see a host immune inflammatory reactions along with some genetic predisposition that, essentially, at least initially, the immune system tries to contain this inflammatory event. But then as this progresses, or if this is not treated, if the plaque is not removed or the calculus is not removed, you then get into this further dysregulation of the host inflammatory and tissue response that actually leads to destruction of the hard and the soft tissue, and then deepening or worsening of that dead space, that periodontal pocket, which then means that you get more proliferation of the anaerobic bacteria because there's more space for them to grow. And this continues on until what you see is you start to actually see destruction, again, of the hard and the soft tissue. So plaque in its early form is a biofilm, and it is soft and it can be brushed off or it can easily be removed. If it is not removed within 24 to 48 hours, it starts to pick up minerals from the saliva, and it picks up calcium and phosphate minerals from the saliva. So your saliva is rich in a lot of different minerals. What happens is that essentially this biofilm becomes calcified. And once it becomes calcified, it's no longer able to be easily removed mechanically. It needs to then be scraped off or actually removed using instruments. You know this as tartar or calculus. And then what happens is that calcified biofilm is now very rough. It is covered in bacteria. The bacteria are collecting more food debris and more minerals, and so that calculus then proceeds to grow. And so essentially, calculus or tartar is nothing more than a hardened bacterial infection. So when you look in and you see this yellow, white, or it could be black, this buildup, particularly on the lingual surfaces of the lower teeth, that's an area where we tend to see a lot of calculus because that's an area that's bathed in saliva all the time. Essentially what you're looking at is you're looking at a bacterial colony. So none of you would let your patients walk around with an ulcer on the bottom of their foot, but if you were to add up all of the ulcerated mucosa in the picture in this mouth, you would have an area of ulcerated tissue about the size of the palm of your hand. And so, none of you would let your patients walk around with a 2-centimeter foot ulcer, but that is smaller than the ulceration that's present in a mouth in a patient who has periodontal disease. And so what you're looking here is, if you look, this dotted line is where the gingiva, the soft tissue, should be. And so what you're seeing, that brownish black plaque on the side of the tooth, that is the calculus. And that calculus has caused soft and hard tissue destruction. So you can see that there's been a loss of soft tissue. The dotted line is where that soft tissue should be, but it is greatly reduced. And if you look at the radiograph, what you can see is the concomitant bone loss. The little bump on the side of the tooth, I have outlined that is actually calculus. So when you can see calculus on an X-ray, there's quite a lot of calculus there. And so what you're seeing is the crown of the root, the root of the tooth, the crown of the tooth, the root of the tooth, and then you can see the bone loss and where the bone should be, as opposed to where the bone is in the area where there is this periodontal pocket. So what are some of the things that you can do for your patients? Well, one, you can encourage them to go see an oral health care professional. But another thing that you can do is you could prescribe them something called chlorhexidine. Chlorhexidine is an antimicrobial. You may know it as Hibiclens, but it does come in an oral formulation. It is a very good oral antimicrobial. It has no systemic absorption. It has no drug interactions. And so you may consider putting your patient on chlorhexidine rinses, which will help reduce some of the inflammatory component that you see associated. Until the patient goes and sees a dentist and actually has the debris or has this calculus mechanically removed off the teeth. This is a little bit of a stopgap measure, but something that you could think about prescribing for your patients. Dental caries, on the other hand, primarily caused by aerobic bacteria. We see it in the oral cavity. And essentially what you need is bacteria, which we all have. You need some sort of carbohydrate source. And so, we say sugars, but it can be any carbohydrates. And in fact, potato chips are highly cariogenic. And a little bit of time, and what you get at the intersection of those three things is you get cavities, which again is the dissolution or the breakdown of the actual structure of the teeth caused by the bacterial, and is essentially again a bacterial infection. So older adults are a caries active group. Caries is a chronic progressive disease. While pathogenesis is not necessarily related to aging, we do see most people will enter into a second round of cavity-prone years, even if they have not had a cavity in many years. And some of the things that can put a patient at higher risk is systemic problems, if they become physically compromised, if they're eating a poor diet that's high in processed foods, if they're on nutritional supplements like Ensure, which are high in sugar, if they're have no access to fluoride, if they have ineffective plaque control, they're not brushing or they're not brushing effectively, if they have a history of dental restorations or dental disease. So the greatest predictor of future problems is past history. And then, that dental work has a finite lifespan, will start to break down. Often you'll see recurrent caries or recurrent cavities around existing restorations or crowns. They're not going to the dentist on a regular basis, so they're not doing any preventive care. And then saliva, and having no saliva is a very high risk of developing cavities. And in patients who have very dry mouth, we tend to see what we call cervical caries. So this is caries that actually forms at the junction between the crown of the tooth and the root of the tooth. And we call these apple core lesions, and you can see why, because they look like an apple that's had bites taken out of them. These tend to form circumferentially, particularly if the patient has some periodontal disease, so they have some shrinkage of the tissue and exposure of the roots in the mouth. And then what happens is these teeth actually will self-amputate. So what you get is a loss of the coronal portion of the tooth. The roots still remain and then have to be removed surgically. So some preventive tips. You can do a quick oral exam at every visit. Again, just looking visually for signs of decay, signs of infection, signs of inflammation. Encourage your patients to go for regular dental examinations. Ask them, are they brushing daily and cleaning or flossing, doing intradental cleaning? If they are at increased risk of caries, if you see active decay, you can prescribe a daily topical fluoride. And, I'm showing you one example. There are generics, so Dental Cream 5000, which is a high fluoride paste that can be used on the teeth daily and to make them more resistant to developing cavities. Patients should be brushing their teeth at least twice a day, once in the morning, once in the evening, using a toothbrush with a small head and soft bristles. You replace a toothbrush when the bristles start to flare or fan out. So that's every 3 to 4 months in general, you should be replacing the toothbrush. Using a fluoride toothpaste, doesn't matter which one, preferably with the ADA seal of approval. And then in addition to brushing, using something to clean in between the teeth. So, I always say there's 5 surfaces to every tooth. There's a surface that faces your cheek, one that faces inside your mouth, the biting surface, and then the 2 surfaces that butt up against the tooth next to it. When you brush your teeth, you can only brush 3 of those 5 surfaces. And so you do need to go in between the teeth with something, and that can be floss, could be floss picks, floss. There's all sorts of things out there, but something needs to go in between the teeth to mechanically clean the surface, the interproximal surface of the tooth. You want to evaluate your patients for health conditions that might make oral hygiene a challenge. So do they have arthritis? Have they had a stroke? Do they have loss of strength, mobility, or dexterity? Are they frail? Maybe they can't keep their mouth open. They might have had weakness after a stroke or an illness, or they have dementia, or some other musculoskeletal problems. So you want to evaluate the same way that you would evaluate any other ADL. So remember, oral hygiene is considered an ADL. Can the older adult do his or her own daily mouth care? Can they hold a toothbrush? Can they squeeze a tube of toothpaste? If they can, then you want to encourage them to do this, again, twice daily as a routine. But if not, then there may be a need to involve a caretaker or look at a way to modify oral hygiene to make it easier for the patient. And again, this is something that, if the patient has a caretaker or needs other help with other ADLs, it may very well be that they are going to need help with performing oral hygiene. There are a lot of different things that we can do to modify the delivery of oral hygiene. And again, this might be, something where you want to find an oral health professional in your vicinity that can help work with you to do this. You can work with an occupational therapist to do this, but there are a number of different things that we can do to make it easier for patients to perform oral hygiene if they do have limited manual dexterity. Toothlets are a no-no. I know these are really popular, particularly in nursing homes and in the hospital. These are great for spreading medications around. You want to spread an antifungal in the mouth. These are not adequate for oral hygiene. They do not adequately clean the teeth, and they should not be used. They are not a substitution to using a toothbrush. And then prevention. We know that at least from a cavity standpoint, we can prevent it by adding, again, supplemental fluoride. So this is prescription strength fluoride. Using things, if the patient has a dry mouth, so using things that can help stimulate saliva, particularly things with xylitol. Xylitol actually prevents fermentation by the bacteria in the mouth of carbohydrates, and so is actually anti-karyogenic. If you are going to have your patient doing something to stimulate saliva, having them suck on candies, please make sure that they are sugarless. You don't want a patient sucking on a sugared, lifesaver. So sugarless, and again, preferably with xylitol if your patients will tolerate it. Dentures, something to just be aware of. Dentures are prostheses. They are replacing a body function. They come in 2 flavors. One is a partial denture. That's the picture on the top. This is when your patient has some natural teeth. And so we're using a metal framework or a metal a device with an acrylic portion with teeth to replace the missing teeth. The bottom is a complete denture, so complete upper, complete lower denture. This is when the patient is missing all of their natural teeth. And so these are made of acrylic and totally replace the dentition. Just some denture care tips you should be aware of. Patients should never sleep in their dentures. It actually is probably the number one reason that patients develop fungal infections or erythematous candidiasis is sleeping in their dentures. Tell my patients, you don't sleep in your shoes, don't sleep in your dentures. The tissue in the mouth needs to breathe. If dentures are not in the mouth, they should be kept in liquid. So they need to be kept wet or moist so that the acrylic doesn't distort. They can be stored in just plain water. They can be stored in water with a little bit of mouth rinse. Cleaning tablets are fine, but they should not be used with patients who have dementia or altered cognition because they may drink the fluid. They may see the cup with water and drink it, and cleaning tablets are not meant to be ingested. And the denture cup needs to be cleaned at least once a week. Otherwise, it will start to grow all sorts of bacteria and fungus because, again, the prostheses coming out of the mouth are covered with biofilm, and that biofilm gets transferred to the container that the dentures are soaked in. However, soaking dentures overnight, even with a cleansing tablet, is not enough. That biofilm should be removed the same way that it needs to be removed off of natural teeth. It should be removed off the dentures. And so daily brushing with a denture brush and liquid soap. We do not recommend toothpaste for brushing dentures. Toothpaste has abrasives in it. That abrasives are meant to remove stain from teeth, but what they do is they actually scratch the acrylic, the plastic of the denture, and then again set the patient up for developing fungal infections. So I usually tell patients use liquid hand soap. Dishwashing soap works really well, but they should be using a brush and some sort of soap to clean the biofilm off the dentures before they store the dentures in whatever solution they're going to be storing them overnight. Again, denture stomatitis is a fungal infection, and you can see this is a partial denture. The picture on the right is of a complete denture. You can see the redness underneath the denture base, and this is again from a candidal infection. All right, so xerostomia in elderly, it is not automatic that all older adults will become xerostomic. We do not see functionally decreased salivary flows or altered salivary composition due to aging alone, but many older adults will have some form of xerostomia for multiple reasons. Probably the most common is as a side effect of medication. And again, there are more than 1,800 drugs in more than 80 drug classes that can cause xerostomia. And if you look at the picture up at the top, what you can see is that thick, ropey, what I call, soap bubble saliva. And what you're looking at, again, is the loss of the serous portion or the watery portion of the saliva, leaving behind this thick mucoid or mucus component. And the best analogy I can tell you is if you've ever had a cold, you take one of those over-the-counter decongestants and you know what your mouth feels like. It's tacky and they're, sore and your saliva feels thick and goopy. This is what happens with medication-related xerostomia most of the time. So again, it sets the patient up for fungal infections along with some other issues. And again, most patients as they get older are taking, multiple medications. So, more than the older your patients are, the more likely they are to be taking more than one drug. So multiple drugs. So the sequelae of xerostomia, we already talked about. It increases the risk of tooth decay. It makes your teeth more susceptible to cavities. The oral mucosa dries out and becomes atrophied, and that means that it is more friable, more likely to be injured, and has a greater susceptibility to infection, predisposes the patients to candida. Patients can have burning or altered sensation in their mouth. So the major cause of burning tongue or burning mouth is xerostomia. It can make it very difficult for them to wear a dental prosthesis because you need moisture to help create suction to make sure that those prostheses are stable and stay stable in the mouth. And then it can cause dysphagia and dysgeusia. Altered taste sensations, you need saliva in order to taste food. And so this can lead to poor poor nutrition and malnutrition. Just a reminder that Candida comes in a couple of different forms. So the most common, or the one that you're most likely familiar with, is pseudomembranous candidiasis. This is when you get those white curd-like plaques in the mouth that wipe off, often leading a bleeding base. But in patients with dry mouth, we often will see erythematous candidiasis, which is does not have the plaques, but has a red, velvety, sort of roughened appearance. This also tends to be more symptomatic. So patients often will have pseudomembranous candidiasis without symptoms. Patients with erythematous candida often will be complaining of burning or pain in their mouth. Again, angular cheilitis, or cracking at the commissures of the lip, is a fungal infection and needs to be treated topically with antifungals. And then again, we can see glossitis, or depapillation of the tongue. So very red, sort of beefy appearance of the tongue, and you can actually start to see fissuring, or what's called scrotal tongue or fissured tongue, in patients who have long-standing chronic dry mouth. Things that worsen xerostomia: Lenman glycerin swabs, again, very popular in hospitals, but they actually make it, the xerostomia worse. Alcohol-containing mouth rinses, strongly flavored toothpaste, or toothpaste that have SLS in it, then caffeine and tobacco. Some of the things you can do to ease xerostomia: there are many, many dry mouth products on the market, saliva substitutes, there are moistening gels. The more well hydrated your patient is, often this can be problematic if patients either are on fluid restricted diets, or as people get older, their drive to drink goes down, and so they often can be dehydrated. The less liquid you have in your body, the less liquid you have in your mouth. They can add liquids to diet and foods to thin them, make it easier for them to swallow. Sucking on ice chips, sucking on sugarless candies. And then there are 2 actual prescription medications, 2 sialagogues that can be prescribed. One of them is Evozac, or Semeveline, and the other one is Salogen, or pilocarpine. These have variable successes. They do have side effects, and patients often will stop taking the medications because of the side effects, one of which it causes profound sweating. It can cause increased lacrimation, increased urination. But for some patients who are really dry, it really can negatively affect the quality of life, and they do, the Salogen or the Evozac actually is very helpful for offsetting some of the symptoms. All right, in terms of treating candidiasis, so topical antifungals have sort of, the pros are they're available over the counter. They have minimal systemic absorption. If your patient wears a denture, you can actually have them use even the vaginal cream. Might be a little bit of a hard sell, but they can buy, over-the-counter antifungals and spread that cream or ointment inside their denture and then wear their denture. It acts like a drug stent, holds the drug against the tissue. That is the biggest con to the topical antifungals, is compliance. So these need to be used often 5 times a day. They need to be held in contact to the tissue. So if you, for example, give your patient nystatin rinse, they need to hold it in their mouth for 3 minutes, 5 times a day. And it can be very, very hard for patients to comply. If a patient is very xerostomic, if they have a really dry mouth, the pastilles and the troches will not dissolve in their mouth. You need saliva to dissolve those. And so in patients who are very dry, those particular formulations won't work. And you should be aware that the nystatin suspension is very high in sugar. So they put in sugar to make it more palatable so it doesn't taste so bad. And that is high in sugar, and again, will add to the carcinogenic burden in your patient's mouth. One of the medications which we often use is something called Orovig. It's miconazole, so it's actually an azole antifungal, but this comes in a tab. It's actually put in the mouth, up in the under the upper lip, in the area of the canine or the cuspid, or your vampire tooth. It actually gets stuck on to the buccal mucosa, and it slow releases over an entire day. So it's applied once a day, and then it's just left there to dissolve and sort of give a slow release. And I have found this to be very useful, particularly in patients where compliance is going to be an issue and where I can't or don't think that a systemic antifungal is the appropriate treatment for them. Systemically, obviously, the pros, it's better compliance, you get better absorption, but the cons are azoles, don't play well with anything. They are potent CYP450 inhibitors, and they have multiple drug interactions, so they need to be used cautiously. They are, again, using maybe using a much more powerful drug than you need in order to treat the condition. But again, they can be useful in patients where compliance is going to be an issue. So, if you have a patient that's just not going to be able to comply with the topical formulations, it may be better to look at using a systemic, provided that the patient can tolerate a systemic drug. And then, just really important, if your patient does wear a prosthesis, that prosthesis is almost definitely going to be infiltrated or infected with Candida by the hyphae. And you need to treat the denture as well, because otherwise, if you're just treating the oral cavity, every time that patient puts the denture back in their mouth, they're going to reinfect themselves. So you can do that by prescribing nystatin. They can soak the denture in nystatin. They don't need to cover the denture completely. What they can do is put enough nystatin in a container, put the denture with the tissue side down, so teeth facing up, tissue side down, because that's the area you need to treat, is the part of the denture that comes in contact with the tissue, and let them soak the denture in nystatin overnight. In patients that are able to do this, they can soak it in water with a very small amount of bleach. So I usually tell patients, put 8 or 9 drops of bleach into a container of 8 ounces of water. And they can soak the denture, again, tissue side down, in the water with bleach. Obviously, denture needs to be rinsed thoroughly, very well, before placing it back in the patient's mouth. And then finally, in dentures that are very old, if the acrylic has become really scratched up, if they're no longer highly polished or sealed, the prosthesis may actually need to be refabricated, because essentially there will be no way to sterilize the denture, and it will just be a continuing source of reinfection for Candida for the patients. All right. So I'm hoping that at least you are able to pick up a few clinical pearls from this presentation. I appreciate your attention, and thank you very much.